Welcome to everybody. It's a pleasure to have you here for this second webinar of the International Academy of Cytology. And also it is a pleasure to have here Professor Maria Lozano for this talk on lung cytology, sample management, diagnostic entities, and implementation of ancillary techniques. I'm very grateful to Professor Lozano because she already did this talk this morning to permit a lot of people with different time zones to participate. It was very well appreciated. So just a brief introduction to Professor Lozano. She has graduated from the University of Navarra in Spain, where she also obtained a PhD there. Then she moved to the United States at the University of Nebraska for a postdoctoral stay. And then when she came back to the University of Navarra in Spain, she get the responsibility of being the director of the Department of Pathology and also the head of cytopathology and molecular pathology in cytology. She's also associate professor of pathology at the Medical School of the University of Navarra. She's well known because she published a lot about lung and pancology, around 200 articles, and she spent for fine needle aspiration and the development and application of molecular techniques in cytological sampling. So it's really a pleasure to have you here, Professor Lozano. And now I leave to you the floor for your talk. Thank you very much.
Thank you, Massimo. And first of all, I want to thank to the International Academy of Cytology and especially Dr. Bongiovanni for his invitation, and Alison because of her nice help. So let's start with my talk. Okay. And I divide my talk in three aspects, these three ones. But before starting, I want to invite you to a virtual trip to Spain, to small part of Spain, of course. And I'm starting with Navarra, where my university is and where I live, of course. And this is a beautiful landscapes, small villages around Pamplona, and very, very, very beautiful places. So I invite all of you to come here because it's a very nice place. And this is Pamplona, and this is the very core of the city. This is called the Plaza del Castillo, and it's a place you cannot miss if you come to Pamplona. So, and these are some pictures of the university. This is the medical school, and these are other buildings of the university. So just starting my talk, we know as cytopathologists that there is a kind of a strategy for diagnosis non-small cell lung cancer and small cell, of course, in small biopsies and in cytology. Of course, first of all is morphology and smears, cell block, whatever type of cytological preparation. Sometimes we need to help of immunohistochemistry, and nowadays we for sure have to use some studies to inform the clinician about biomarkers. So let's start with the point number one. So why is so crucial sample procurement and management of the sample? Because we are involved in the personalized medicine world. That means, of course, prevention, but means accurate diagnosis to be able to establish a specific therapy for a specific patient. So this is what we call the personalized medicine. And we know there are many challenges in the diagnosis of lung cancer. As a cytopathologist, we are asked for comprehensive and complex diagnostic using minimally invasive procedures. And of course, we have to mix this diagnosis in the world of personalized therapies. So integration of biomarkers in the clinical management of the cancer patient is a necessity. But at the same time, and unfortunately, many patients, more than 50%, 50-60% of the patients with non-small cell lung cancer came for the first time to the hospitals at advanced stages. So these patients cannot, are not candidates for surgical procedures. So from these patients, what we have is only cytological material and or small biopsies for perform the diagnosis and all the biomarkers studied. At the same time, there is a development of imaging techniques that allow for non-invasive approaches, and we obtain the same type of samples, cytological material and or small biopsies. So without any doubt, fine needle aspiration and fine needle aspiration biopsy are in the first line in the management, not only in the diagnosis, but in the management of a patient with non-small cell lung cancer. And why? What is the role? Why is cytology so important in this setting of precision medicine? Because many reasons. Here I put only 4 reasons because there are other more. This is a least invasive method for tumor material procurement. We can have a pure, more or less pure population of neoplastic cells in many cases. There is the only method in some cases, like non-small cell lung cancer states, advanced states, and for example, pancreatic tumors. And for example, in metastatic disease, there is no need for the calcification when we are doing a fine needle aspiration for bone mets, because we know that some antibodies, for example, for immunohistochemistry, don't work very well in decalcified material. So let's see, let me give you 2 examples of what I consider the day-to-day personalized medicine and cytopathology. This is in Spanish for sure, but I'm going to translate this a big amount of clinical information, as you can see here is pericardial fluid, and the information we have is pericardial fluid, and we receive 425 mL of hemorrhagic fluid. So this is the Pap-Nicolau Steiner smear of the fluid. We can see here these cells and these mesothelial cells here and here too. But because we have to review, of course, the clinical chart of the patient, so we decided to perform TTF1, and TTF1 has a nice nuclear positivity. We made, of course, a cell block. And at the end, just with these 2 slides, we can diagnose the patient as having a lung adenocarcinoma, stage 4, and in the cell block we perform more studies. So AL was negative. PD-L1 using 22C3 clone was also negative. And we performed a study of EGFR, and we found a mutation, a deletion of exon 19 of EGFR. So this is a kind of very simple precision medicine. Now let me show you just this. The second case is a young lady, 32, non-smoker lady, who came to our hospital with a very, very disseminated disease. So we decided to do a fine needle aspiration of a direct fine needle aspiration of a supraclavicular lymph node, and we found this lesion. This is a signet ring cell tumor metastatic to the lymph node. With the PAS stain, we see nicely the presence of mucin in the cytoplasm of these cells. And the patients had a lung mass and metastasis everywhere in the body. And because she had a lung mass, we perform a TTF1 staining. There is a nice nuclear positivity. And because of the age and the morphology of the tumor, we perform a FISH for ALK. So here is the separation between the green and red signals that confirms the presence of ALK translocation. So I think we can all call these examples day-to-day of routine precision medicine. And as cytopathologists, we know that we are asked to do more with less. And in advanced lung cancer and in other tumors too, most of these tumors are diagnosed using minimally invasive procedures from which we get just small samples. And this is a schematic representation of the different ways to get samples from lung and mediastinum. It depends on the location of the lesion. Let me give you just a few words about this approach, is electromagnetic navigation, because I think it's not widely used in many centers so far, at least. What is this? This technique is similar to a GPS, the GPS of our cars, and this system guides a biopsy tool or a needle, most frequently a needle, to peripheral nodules, but these nodules has to be at least 8 millimeters inside. It requires a CT planning and is recommended to use low-dose CT, especially if the CT has to be repeated. So with this technique, the software generates a virtual image based on the CT, and then it allows navigation with electromagnetic guidance to peripheral lesion and even our lymph nodes. And the important thing is that the software uses a small virtual camera in the airway to identify the potential route to target lesion. But the important point of this technique to be effective and to be sensitive is what we call the bronchus sign. The bronchus sign is this one: is the lesion has to be in the way of the bronchi, because the needle goes to the bronchi and stops because the lesion is here. If the bronchus sign is not, the sensitivity of the technique decreases a lot. And this is an example of this nodule. We did. This is a 79, I think, years old female who was passive smoker for. And here is the cytology and the biopsy. We get this smear, very nice, with this cytonuclear inclusion. Santityp1 was positive, and on the cell block is a very nice. Well, it's not a cell block; it's actually a biopsy. We found this lesion, which is adenocarcinoma with lipidic growth. So. The important question, I think there are two important questions. First one, how to ensure accurate diagnosis using minimal invasive methods? And the second one, and most very important, I think, is how to provide all patients, not some of them, all patients with the benefit of effective therapies. And the answer is with adequate samples and with an adequate management of the samples. And we have to be able with these samples to give an accurate morphological diagnosis and to make analysis of biomarkers, all the biomarkers that oncologists need to properly treat these patients. So one aid we have to achieve this goal is doing ROSE. I love ROSE. It's a lot of work, but I love ROSE because it's a very effective technique. To me, the most important part of ROSE is this one: we can control pre-analytics, and this is very important if we want to do ancillary studies in these small samples. So, what are the advantages of ROSE? We can make in situ a preliminary diagnostic approach, but we can redirect the procedure. We can redirect the echoendoscopist of the bronchoscopist in the way to obtain a necessary amount and quality of material for the studies we anticipate according to the diagnostic suspicion. And importantly, we can prepare in situ the sample for the studies we anticipate we are necessary. So we try to get cell block, of course, wherever it's possible. It's very important in the way everyone do cell blocks. We like to do a needle wash and liquid-based cytology at the end of the procedure because this fixative preserves very well DNA and RNA. Of course, fresh material, flow cytometry is required. We anticipate a lymphoproliferative lesion, and we anticipate that we will need flow cytometry. And there is a development of new needles nowadays that allow, in many cases, at least in some cases, a direct collection of cell block. We can obtain very thin tissue cores, so we obtain directly these thin cell blocks. And of course, it's very important a careful smearing and adequate alcohol fixation. So ROSE is a teamwork between the interventionist, of course, the cytotechnician, and the pathologist, the cytopathologist in this case. And this is proof by many, many important people. And this is the conclusion of the members for the Pulmonary Pathology Society, is published in 2018. And the conclusion of this paper is that ROSE is essential not only to establish the diagnosis, but for adequate processing of the samples. And another important conclusion is that cytopathologists must know the scope, the peculiarities and needs for biomarkers and for molecular techniques. But when we talk about cytology, some critics that came to us is that we cannot keep, or we lack the architecture of deletion. So the question is there any possibility to preserve the architecture of the sample during fine needle aspiration? What do you think? Yes, no, maybe? Okay, let's give the doubt a chance. Let's see. Because we are assisting to a development of new needle, is what I call NGN, next generation needles. And these needles allow to, in some cases, at least in some cases, to directly obtain very thin cylinders of tissue. And second, NGP, next generation procedures. This is a technique called wet suction, and actually it was published in 2015, as far as I know, but it's not very well, very used in many hospitals, but it's very nice. It was designed for use fine needle aspiration, but can be performed also doing EBUS. And the thing with this technique, the rationale is to fill with a small amount of physiologic the syringe, so we increase the aspiration pressure, and we obtain this. This is a real case using through EUS fine needle aspiration. We obtain these cylinders. And with this technique, the conclusion of this paper is that it results in significantly better cellularity and specimen adequacy in cell blocks using this technique. But the tricky using these two approaches on new needles, on new procedures, at least in our experience, we have been doing this for a bunch of some years already, is very important to introduce the sample, which is inside the needle, to introduce the sample directly in formalin very slowly. Because the sample is very thin, it is getting fixed while it's entering into the formalin. And in that way, we can preserve the architecture. So of course, every technique has advantages and disadvantages, in these techniques rely mainly on the skills and experience of the doctor who performed the procedures, so the endoscopist or the bronchoscopist. But for us pathologists, it has many advantages. We can combine the information of cytology fixed in alcohol and paraffin, fixed in formol, of course. We can choose the most appropriate sample for each technique. Of course, it's good to have a cell block or a tissue to do immunopsychochemistry, but at least in our experience, we prefer to infuse and cytological smears. We'll see the reason a little bit later. Some patients can benefit for this because, as you know, clinical trials don't allow cytological samples, but they do accept paraffin samples. So thanks to these techniques, some patients can benefit and can be enrolled in some clinical trials. And we can, of course, perform more complex molecular studies, including the study of the immune microenvironment. So let's move to another place of Spain to continue with my talk. And this is the north of Spain. These are the Pyrenees in Aragon. Aragon is a region very close to the Pyrenees, and is the place where I was born in that close to that place. No, so in the north, but close to that place. This is the Pyrenees in the winter and in the summer. So anyway, it's so beautiful. And let's go to the second part of my talk, is the diagnostic entities. So the thing is that the WH classification for small biopsies and cytology is similar to what that was proposed in 2011 by the International Association for the Study of Lung Cancer, the American Thoracic Society, and the European Respiratory Society. And the main idea of this classification is that for small biopsies and cytology, the recommendations is that non-small cell lung cancer can be further classified into more specific type, adeno or squamous, whatever. And they recommend that the term non-small cell lung cancer, non otherwise specified, be used as little as possible. This is the main goal. To do that, they recommend to perform some limited immunohistochemical studies, a single adenocarcinoma marker, to give one I'm using, and a single squamous marker, P40 or P63. So carcinomas lacking clear differentiation by morphology and specialist strains are those who are classified as non-small cell lung cancer, no otherwise specified. And they recommend that every institution has to develop a multidisciplinary tissue management strategy to obtain this small specimen, process them properly, but not only for diagnosis, and also for molecular and biomarker tests. And this is a table in this paper that I'm talking about, and where the authors show a comparison between the classification, the diagnostic classification of adenocarcinoma, squamous, and large cell carcinoma in resection specimens and in small biopsies and cytological samples. So we can understand cytopathologists and surgical pathologists, we can understand perfectly, because thanks to this, we are talking the same language. This is the last edition of the Papa Nicolaou Society of Psychopathology System for Reporting Respiratory Cytology that is being published in 2019. The experts gave us 6 diagnostic categories: non-diagnostic, benign, atypical, neoplasm, suspicion, and malignant. Of course, I won't go through every category, because this is not the I can stay talking about this my whole talk, and it's not the goal of my talk. But this is that we follow most of us, and in the way we talk the same language. But what next is coming soon. The WHO, together with the International Agency for Research and Cancer and the International Academy of Cytology, is preparing an international system for reporting lung cytopathology that I think is coming up soon. But the thing is that sometimes for us cytopathologists, it's very easy to diagnose cancer by cytology. Look this case. This is 1, 2, 3, 4 cells, and with these 4 cells, we can say that this is an adenocarcinoma without any doubt. And look at here the nice bronchial cells with the cilia here. If we perform a PAS stain, which is very cheap and very easy, we can see the mucus, the mucin in the back walls of these tumor cells. So sometimes as you see, it's very easy to diagnose another carcinoma. Sometimes also, like here, it's very easy to diagnose an squamous cell carcinoma with these keratotic cells, the necrosis, and the more poorly differentiated squamous cells, so it's nothing to say about this. Here is another nice example of a squamous cell carcinoma with many variations among the tumor cell that is typical for these tumors. And in some cases, even we can talk about the pattern of the tumor. In this case, it's an adenocarcinoma with microcalcification, and we can say that at least in some extent, this tumor has a micropapillary pattern due to these groups of cells. And this is another example of a lung tumor with psammoma bodies, a lot of psammoma bodies, and these irregularities of the nuclear membrane, even with groups like thyroid papillary carcinoma, and even with site inclusion like thyroid papillary carcinoma, and in this case TTF1 is positive, the patient has a lung mass with mediastinal lung metastasis. With this, in this smear, there is no problem to say that this is a mucus producing adenocarcinoma. And here there is no problem for any of us to diagnose a small cell carcinoma. If you see this case to a higher power, you see the crush artifact of the chromatin and the nuclei hyperchromatic without nuclei, and with this more than not so small cell. In the small cell carcinoma, there are cells that are not so small, in this case here, but the nuclei of these cells is the same like the other cells. So this is I think a very nice picture of with all the cytological characteristics of a small cell carcinoma. What about neuroendocrine neoplasms that are not a small cell carcinoma? This is a case of a carcinoid tumor. This is a very nice, sometimes avoid a little elongated nuclei, some vessels, the salt and pepper chromatin, and here you can see the characteristic of this carcinoid. And here is another neuroendocrine tumor with the cells is a low power, but you can see this delicate cytoplasm. Here, and we have the help of immunocytochemistry. In this case, synaptophysin and chromogranin were positive, so the diagnosis is straightforward. And this is another case. You can see here the differences in size of the nuclei, which is a characteristic of neuroendocrine tumor, as you know, and the delicate cytoplasms that is different amounts on different cells. In this case, the tumor is positive, strongly positive for synaptophysin, focally positive for CD56, and I won't talk about the big issue of Ki67 in cytology in neuroendocrine neoplasms. This is for another topic. But sometimes we have tumors that is not so easy to subtype between, for example, adenocarcinoma or squamous or large cell or whatever. And so then we have we need some aid, we have to go and to do some immunos. In non-small cell lung cancer, the palette of immunohistochemistry is very short and very easy, because TTF1 is very useful for at least more than 70% of adenocarcinomas, and P53 or P63, sorry, and P40 is positive and is very useful for diagnosis of squamous cell carcinoma. And here, this is the typical pattern of adenocarcinoma, TTF1 with nuclear positivity and cytokeratin 7 cytoplasmic and membrane positivity, and TTF1 negative and P40 or P63 with nuclear positivity in squamous cell carcinoma. Let me show you some examples. This is a fine needle aspiration of a left adrenal gland. It's easy to diagnose with this smear adenocarcinoma, but if TTF1 is positive, it's easy to we are confident that the origin is lung. This is another case of a supraclavicular lymph node. You see the case. I'm not sure if just with this picture any of you are able to guess an origin of the tumor. We make a PAS because in Papa Nicolau we can see some vacuoles. The vacuoles are positive, so the tumor has mucin on it. And with TTF1, there is a nice nuclear positivity, so the origin of the tumor is the lung. And this is another example of another mediastinal lymph node. You see here the smear, probably is a squamous cell carcinoma, but it's easy to have a strong nuclear positivity with P40 to be more confident in our diagnosis. This is another case of a lung mass. This is a lung mass with a very ugly tumor. And fortunately, TTF1 was strongly positive, so there is, of course, poorly differentiated adenocarcinoma. But the real life is sometimes different, and we have many times tumors. This is a cell block, and this is the smear, a stain in the smear, where TTF1 and P40 are negative. What we can do with these tumors? Well, what is recommended is to follow the panel with cytokeratin 7, NATSIN, and don't forget neuroendocrine markers, because probably we don't use many neuroendocrine markers, but many adenocarcinomas, or at least a bunch of them, have a neuroendocrine differentiation if we perform neuroendocrine markers. But we have to keep in mind new markers. For example, SMARC-C4 is a new antibody that when it's lost, when we lost the positivity, is a nuclear positivity. Some adenocarcinomas are positive for SMARC-C4, and it's a nuclear positivity, but it's been published that some adenocarcinomas that are TTF1 negative are lost SMARC-C4 expression. So this is important because it seems that adenocarcinoma tumor that lost SMARC-C4 are a different subset of adenocarcinoma with different therapeutic and different characteristics, different implications. And the other new, well, it is not new, but it's important marker that we have to keep in mind is NUT. And let me show you an example. This case is a courtesy of Dr. Laviano, and these are the real picture from the microscope. It's a very young or male, 40 years male with a lung mass and with metastatic disease. And here you see the small, medium-sized cells with scanty cytoplasms, very, very lightly basophilic cytoplasm. And we were discussing this case, and we decided to start to try with NUT, and we found positivity in the nuclei of the tumor cells with this antibody. But be careful, because immunohistochemistry has no brain. We have to use our brain. And the first is morphology, and based on morphology, we use specific antibodies. We cannot use a lot of antibodies, and yes, to try what is going to happen. We have used our brain. It's something that I say my residents every day. And a second situation is that, or a second reason is that not all is what it seems to be. Look this case. This is a patient who has one lymph node, mediastinal lymph node, and two pulmonary lesions. And we did the rows, and this is and we get the sample. And we were in the procedure. We were informed that the patient had a long history many years ago of melanoma. So we decided to study deeply the lesion, and we performed Melan A, which is nicely positive in the nuclei of these cells, the big one and the smaller one. And in this case, the patient also harbored a mutation in the exon 15 of BRAF gene. Another case, this is a patient with mediastinal lymphadenopathies. The clinical suspicion was tumor, tumoral disease, and we found many non-necrotizing granulomas, like this one and like this one, with these nice epithelial cells without necrosis. And in the follow-up, the patient at the end was diagnosed as having a sarcoidosis. And this is another case of a 65 male with mediastinal lymph node. And we did a fine needle aspiration. This is a lot of necrotic debris here. And this is a silver stain. And at the end, the diagnosis was nocardial infection. No tumor, no nothing, no cardiac infection. Let's move to the next part of my talk, and let's move to another place of Spain, is La Mancha. more or less in the center of Spain, is La Mancha, is the land of Don Quixote and Sancho. It's an amazing book. It's like a treasure. Don Quixote de la Mancha has been written by Miguel de Cervantes. I recommend to read it to you because it's plenty of adventures and very, very, very nice. And this is a place very far from La Mancha. This is Tenerife in Canary Island. This Tenerife is a volcanic island, and here is a volcano called Teide. It's Teide. And close to the Teide, just round behind the Teide, is the sea. So it's a very, very beautiful, beautiful place, Canary Island. Highly recommendable also. And let's go to the third part of my talk, which is about implementation of ancillary techniques. And why? Because nowadays it's mandatory the integration of biomarkers in the clinical management of lung cancer patients. And biomarkers in cytology poses us some challenge and of course some opportunity. Every challenge goes with some opportunity. And this is the nice part of our profession, I think. But we cannot forget that the morphology is the first biomarker. We are thinking and we have to transmit to our residents that, okay, we can do immunopsychochemistry, NGS or whatever. But the most important thing is the morphology. Everything is based on our morphological diagnosis. And this is so important because, yes, with this image, this is a squamous, of course, squamous cell carcinoma. Oncologists know that there are some drugs that cannot be given to this particular patient, but there are others that can be given to this patient. So there are therapeutic variation in the different morphological subtypes of non-small cell lung cancer. So morphology is the first biomarker. Okay, said that, look at the slide. These are theoretically patients with the same diagnosis and the same clinical stage. So they are all non-small cell lung cancer at stage 4. But if you see this patient is a male 65 with a squamous carcinoma with a mutation of the RAS, male non-smoker adenocarcinoma, ALK translocation, a woman 39 non-smoker adenocarcinoma with a mutation and EGFR gene, and a 57 non-smoker adenocarcinoma with no expression of PD-L1, and a male smoker with a high expression of PD-L1. We know, of course, oncologists know, but we as pathologists know that these patients have different tumor types and they will receive different treatments. And let me show you a real example. And this is a very real example. It's dates from 2009, but it's very nice. I think I like when I saw these cases. This is a female, a 72 years old female non-smoker who came to our institution for a second opinion. She has been diagnosed as having a disseminated disease of unknown origin. The patient at that moment has also brain metastasis, and she had been only offered palliative treatment. So this is the PET that she came and she gave to us from her institution. So we decided to start with the easiest part of the diagnostic workout. So we perform a direct needle aspiration of the supraclavicular lymph node, and we obtain this lesion. It's easy for all of you to diagnose adenocarcinoma with this picture. Okay, so because the patient has also lung masses, we did an histochemical analysis with TTF1 and cytokeratin 7, and at that time we were using Sanger sequencing, and with this technique we were able to detect a deletion on exon 19 of EGFR gene. So the patient was diagnosed through this simple method as having a metastatic adenocarcinoma of lung origin with deletion in exon 19 on EGFR gene. Look at what happened after 3 months of treatment with tyrosine kinase inhibitors. This is the PET. So this made us very, very happy. We feel useful for clinicians and for patients. So it's the good part of our profession. And now in 2018, the most important association of pathologists in the United States and the ASCO, the Association, American Association for Clinical Oncologists, are in agreement, and they stated that any type of cytological sample is useful for biomarker analysis. Before of that, only cell blood was considered useful for biomarker, but after 2018, any type of cytological sample is useful for biomarker. And as Dr. Lindemann said in this paper, any cytology sample with adequate cellularity preservation may be tested. And this is very important because currently most of these biomarkers can be tested and actually are tested in small biopsies and in cytological samples. And there are many recent references in the literature about how to handle these samples for biomarker analysis and etc. And this is a schematic a workflow that a schematic representation that we have been published very recently in this paper, talking about how to perform algorithm using samples obtained by use or EBUS FNA using rows from, of course, for non-small cell lung cancer. So if we get adequate samples for morphological diagnosis and for biomarkers, that's perfect. If the diagnosis, remember diagnosis, morphological diagnosis is the first biomarker. If the patient has a squamous cell carcinoma, the guidelines recommend to perform PD-L1. Oncologists are starting to require many more markers than PD-L1, but the guidelines said that for squamous cell carcinoma, we have to do PD-L1 as you know is performed using immunohistochemistry. If we diagnose adenocarcinoma, or if we diagnose a squamous cell carcinoma in never or light smokers or patients under 50 years old, we have to do the entire panel. And the basic, I would say, basic panel is here, is PD-L1, ALK, ROS, EGFR, BRAF, PET, MET, exon 14, and NTRK. Some of these biomarkers are performed by immuno, some of these by FIS, and some of these by PCR. Let's see later. If we don't get adequate samples and the samples is adequate for morphological diagnosis only, that's okay, but we need more samples to do biomarker. So the question is, it is possible to repeat the procedure? If the answer is yes, it's okay. We follow this part of the algorithm. And it's not, well, we have to transmit to our clinicians that we only can perform a morphological diagnosis, which is very important. But in case of non-small cell lung cancer, the diagnosis is clearly incomplete. But this is a never-ending story. And this is a very, to me, I think it's a very nice picture published by Paul Butterland and Cancer Psychopathology last year. And look at here, a lot of biomarkers, a lot of molecular alteration related with non-small cell lung cancer. So as I say to you, this is the never-ending story. We have to be ready for this because this story is real, it's happening now. Let's start with immunohistochemistry, some word about immunohistochemistry. There are very many papers published in the literature, but there is a paucity of articles outlining the best practice guidelines for immunohistochemistry using cytological samples. Actually, many of the laboratories are performing diagnostic immunocytochemistry without adequate validation and without adequate quality controls. But at the same time, there is a good evidence that with appropriate modification in analytical factors, immunocytochemistry and non-cell block preparation can be equivalent to immunohistochemistry and paraffin embedded samples. And as in Paraffin samples, there are some pre-analytical factors that has to be taken into account when we try to perform immunohistochemistry in cytological samples. We have to be aware of the fixatives and the fixation, the type of cytological preparation, stains, cover slating and mounting media, and antigen retrieval. What happened with cell blocks? With cell blocks, there is no problem because they are fixed in formalin, so everything is similar to any formalin fixed and paraffin embedded tissue sample. So that's it. But what happened with non-cell block preparation? For example, with smears. In our experience, we prefer to do the immunohistochemistry on this type of cytological samples and Papa Nikolai stained smears. And the reason is that we know the cells we want to analyze. So we see in the Papa Nicolau and we do the immunohistochemistry on the same slide. So we are sure we are analyzing the cells we want to analyze. Regarding cover slipping and mounting media, we prefer, and we use in the department, we use plastic cover slipping, and it works very well because it takes like 1, 2, 3 minutes to take it out using acetone. Otherwise, if we're using crystal cover slipping, that has to be soaked in saline for hours and even for days. So using plastic cover slip, we can short the time to give the results. And regarding antigen retrieval, in contrast to formalin, which everybody knows that is a cross-linking fixative that masks most epitopes, alcohol-based fixatives work by causing tissue dehydration and protein coagulation. So the majority of antigens do not require any form of antigen retrieval. And this is very useful and very important when we use cytological samples which are fixed in alcohol. And the good point is that, and that has been published in the literature, that we can use same protocols and same platforms that we use with paraffin samples. And actually they work very, very well. This is a table that summarizes the type of cytological samples, fixative results. So cell block is no problem, it's formalin, and we have no problem with the results. Papa Nikolai stained smear are fixed in alcohol 96, and we get comparable results to surgical samples. And stained smear are also fixed in alcohol 96, and stained smear are okay in our experience, a little bit lower with results because we don't know the cells we want to analyze. So it's more straightforward to use Papa Nicolau because we know the cells we want to analyze. Liquid and air dry smears don't have fixative, and there is a lightly high rate of false negative results, a little low intensity of immunostaining. Same happened with liquid-based cytology, which uses methanol-based fixatives, and having the same, a little bit low intensity of immunostaining and high rate of false negative. But what is important is this: we need a rigorous validation and protocol optimization that has to be performed in each laboratory that want to perform immunohistochemistry and cytology specimen in any kind of sample. And one thing is that there are practical difficulties and lack of standardization performing immunohistochemistry and non-cell block cytological preparation. And this is, to me, the most important disadvantage, and something we had to work together to get to overcome this problem. So in this paper published by the International Association for Study of Lung Cancer for the group of pathologists, they make some conclusions, some interesting conclusions. They said that without any doubt, cytology specimens are under use for predictive cytochemistry testing. They recognize there is a practical difficulties in standardization. Is a very, very important aspect we have to work on. And by they conclude that with proper optimization and rigorous quality controls, high quality staining can be achieved on non-cell block preparation. Here are some examples. I choose ALK because it's a very, very useful antibody in non-small cell lung cancer. Here, these are all cell blocks. And these are smears. If you want to perform on smears, we have to do thousands of FIS to confirm that your intensity on this smear is a real positive, is not a real positive. Contrary to cell block and paraffin tissue, we know that positivity, ALK positivity is a strong granular and cytoplasmatic positivity, but a smear is the same, strong granular and cytoplasmatic, but you have to do a lot of FIS analysis to prove that your positivity on a smear is real. So every lab has to perform their own controls, very, very strict controls. 2 words about FIS. What is about FIS in cytological samples? The main advantage is that a nuclei on cytological smear is entire. So we can analyze the real signals in these nuclei. Any type of cytological samples can be used. FIS work equally on stained, unstained, and pap-stained, GEMSA stained smear, wherever. And this is a reality that the quality of DNA in air dry or alcohol fixed cytological specimen is better than after formaldehyde fixation, and the hybridization is better. And if you go to this book and you go to page 24, you can read this. Smears may be preferable to histological section for all fixed testing because they eliminate the nuclear truncation and any related errors. So page 24 of the WHO book. What we recommend, and everybody recommend doing FIS on smears, of course, avoid these areas with overlapping nuclei because we cannot analyze the signal on individual nuclei, and go to these areas when the nuclei are isolated and we can interpret the signal. Some authors recommend that we have to analyze 50 cells. Actually, we analyze at least 100, and we recommend to analyze 100 cells. And there are many papers in the literature showing the success of doing FIS on smears. What we do is just select the area of interest where the cells are. We analyze nuclei, isolated nuclei, and don't waste the proof for the whole smear. And here we can find very nice results. This is a real, one of our cases. This is a fish performing a different stained smear. We want to analyze this part of the smear, and here is the results with the positivity for ALK. And this is a rose one in a pap stained smear. Same, we choose this part of the smear. This is the real image, and this is the makeup image. But we can see here easily the positivity for rose one. And following this figure in the paper of Paul van der Laan in cancer cytopathology, the thing is more complicated. This story is never ending actually, because we have to deal with biomarkers for immune checkpoint inhibitors. And we know that so far PD-L1 tested by immunohistochemistry is the only available marker and the only validated marker. So pathologists, and especially cytopathologists, have been challenged to perform many assays with a very limited sample. This is a paper we published very recently, of course, because we published it. I recommend you to read it and let me know if you like it. But in this paper, we talk regarding PD-L1 in cytological samples about the procedure, rows, the adequacy of the samples, fixed actives, antibodies and plant or controls, and interpretation. And I like just to know to say that the interpretation in cytology in smears and cell block is the same. Is partial or total cytoplasmic and membrane immunoreactivity of any intensity, but we have to be aware of the three-dimensionality of cytological smear, and because it can give us a wrong interpretation of cytoplasmic staining, and it's not real. It's due to the three-dimensionality to the overlapping of the cells on a smear. For controls, we prefer to use placenta for the reason that we can perform smears of the placenta, stain this smear with Papa Nicolau, and use for positive control when we are doing PD-L1 on smears. And of course, for cell blow, we use pieces of placenta, paraffin, formalin fixed and paraffin embedded. So paraffin for cell blocks and smear for smears. This is what we do. And what do we have to take into account in our reports? It's important to specify the type of cytological sample, cell block, smear, whatever, the clone use and the control use. And we recommend, and in the literature is recommended to evaluate at least 100 evaluable tumor cells, and as always, very important, pre-analytics. And now the new tools, the digital pathology is coming to help us, I think. And we are starting a little project with using cell blocks and trying to compare the algorithm for PD-L1 with our eye interpretation. And we are using this system, this UPath from Roche, and this is a very preliminary study, and we want to finish it and have the opportunity to show to you in some meeting. But what is beyond PD-L1? Beyond PD-L1, there are many things. One of them is the complexity of tumors, because tumors are not only tumor cells with all the tons of genetic alteration. These cells are in a macro environment, and in this macro environment, we have blood, lymphatic vessels, macrophages, B cells, T cells, dendritic cells, etc. And the point is that we know that there are tumors which are called cold tumors, are not inflamed tumors that typically do not respond to immunotherapy. And on the other hand, there are hot tumors or inflamed tumors that typically respond to checkpoint inhibitors. These hot tumors or inflamed tumors have a lot of tumor-infiltrated lymphocytes, express and high levels PD-L1, have more CD8 positive cells, they have genomic stability, they have a lot more a higher tumor mutation burden. So we know all of this, but what we don't know so far is how to convert one cold tumor into a hot tumor. Actually, this is the last piece of the puzzle. But we have devices to analyze this macro environment. In our department, we use this Vectra Polaris device, and it allows multiple cellular phenotypes to be visualized and quantified simultaneously in the same tissue section. Let's see how it works. This is an example of an adenocarcinoma. We use these different antibodies. We do immunohistochemistry, but the antibodies marked with a fluorescence substance, and we perform different immunohistochemical analysis over the same slide. Every antibody is marked with a different color, and at the end, the system put together all the different images of the different antibodies, and we see at the end the distribution of the immune cells in the interstitium, and also the relationship of some immune cells with the tumor cells. And this is also a quantitative analysis, and every bar corresponds to a different tumor, and we can have a proportion of different cells on each tumor. And in our department, we design a panel, a very small panel with at least 5 antibodies, because this is keratin and this is DAPI, for non-small cell lung cancer. This is a very preliminary study, and this is a resection specimen, but in this panel for non-small cell lung cancer, we decided to add N2 macrophages that are, this is the antibody for N2 macrophages, CD168. And look at this funny case. This is the It seems that M2 macrophages polarize around nest of tumor cells in the way that they want to protect the tumor cells from the attack of immune cells. So it's a funny picture. I think it's not happening in any tumor. We don't know why some tumors have this distribution of M2 macrophages and some others no. But we don't have clinical correlation so far. But we want to keep working on this because I think it could be very interesting. But what about in cytology? It is possible to do. So far, it is a very preliminary analysis, and we are doing the same panel in cell blocks obtained in the way I talked to you before, with these tiny cylinders that get fixed in formalin very slowly when they enter into the formalin. So let me show you an example, two examples. This is an adenocarcinoma, the antibodies separately and the antibodies all together. And here is the distribution of different immune cells in the stroma, and very few in the related with the tumor cells. This is another cell block, and the same, the different antibodies and all together with the distribution in the interstitium, and some of them related with tumor cells. So with the relation to this, we just published a paper. It's a very preliminary study trying to validate this technique, the multiplexing immunofluorescence in cell blocks from non-small cell lung cancer. And the preliminary conclusion is that the implementation of multiplexing immunofluorescence assay on cytological samples seems to be feasible and can be used to explore the immune environment of non-small cell lung patients who are not candidates to surgery. And just to finish, let's move, sorry for being a little bit late, to the south of Spain. This is Granada, and this is a nice view of the Alhambra, another nice view of the Alhambra, and this is one of the many places inside of the Alhambra, which is a very recommendable place to visit. And this is another city from the south, is Cordoba. This is the Mezquita in Cordoba. And this is a very peculiarity of this city. These are called patios. And these narrow streets are decorated with a lot of flowers. And even there is a competition in the city to see which street and which house is more decorated with more flowers, more beautiful, etc. It's very beautiful. So another place to go. And just to finish, because there are so many alterations, if we want to detect a lot of biomarkers using these tiny small samples, we have to be familiarized and we have to use NGS. At the end, we have to use NGS. Does cytology have a role on NGS? Of course. Cytology is a very good source of DNA and RNA for NGS studies. For two reasons. Because we need a small amount of DNA with 10 nanograms per microliter is enough for DNA. And because the DNA and the RNA are very good quality, with samples fixed in alcohol. So we like to use to perform NGS if it's possible, if the sample is good, starting from smears, stained, pap stained smear, deep quick stained smear, or unstained smear. But we have to know the amount of cells we have on the smear. So we have to be aware of tumor cellularity, tumor fraction, which means the relationship between tumor cells and the total amount of cells of the samples, and of course fixation is important, that the sample is well fixed. And here are 4 different examples from all of them. NGS will work for sure. And there are validation studies and mutation using smears, cytological smears. And these studies have been published in 2018 and 2019 by the International Molecular Cytopathology Group led by the great Professor Giancarlo Troncone from University of Federico II in Naples. And now is in press another study of translocation using also cytological smear. We hope to be published very soon in Cancer Psychopathology. So thanks to the effort, especially to Professor Giancarlo Troncone. And regarding NGS, the pros of the technique is we need a very low DNA, so we can perform NGS with DNA in tissue, cells, and blood. But we can get lost with many information that, of course, we as a pathologist don't understand. So we need good molecular biologists or molecular pathologists to help us with this, because we can make a small conclusion about NGS in cytological samples with this slide. NGS is a useful tool for the analysis of molecular alteration in cytological samples. Starting for limited material allows the simultaneous analysis of many genes. The use of rows maximizes all cytological samples for molecular testing. We digitalize the slides prior the molecular studies because we lost the slide, so there is a need to digitalize the slide. With stained smear, with cytological smear, we know that the quality of the DNA and RNA is better than paraffin. And of course, very important, pre-analytical standardization, protocols, internal validation, and quality controls. And let me show you to end one case that relate all this I'm talking to you today. This is the case of a male, 60 years old male, that has been suffering for a very painful ischemic heart disease. Is former smoker for 35 years, and in the study of his heart disease, they perform a CT scan and they discover a paramediastinal left upper lobe mass, very big, already 8 times 5 centimeters, with lymph nodes and liver mets. We perform a use-guided fine needle aspiration, and the diagnosis was lung adenocarcinoma, EGFR, BRAF, KRAS, ALK, and ROS negative. We perform an IDILA analysis because it was requested by the oncologist because the patient was a very bad condition, and the oncologist wanted to know as quick as possible if there were any gene, any possibility to targeted therapy. And we found a PD-L1 expression higher than 50% of the tumor cell of this patient. Here are the smear of the cell block. I'm sorry because there is no beautiful cytology, but this is what we had in these cases, and this is the real case. So these are the tumor cells on the cell block. TTF1 was positive. And I want to show you the PD-L1. We performed PD-L1 on the smears and on the cell block, and the positivity was really high. So the oncologist decided to give immunotherapy to the patient, but the patient did not respond to immunotherapy. And then the oncologist requests a panel and NGS to see if there is any other information that can help the patient. And on NGS, we confirmed the mutation of KRAS we found during IDILA, but we found another mutation, STK11 mutation, that this is in Spanish because this is our report, but these mutations confers de novo resistance to immunotherapy. So what did we learn from these cases? What this is the most important to learn from our cases and from our mistakes. We learned, if you remember the paper of Paul van der Laan, they said that there is genetic aberration that modulate targeted immune therapies. And this is a paper from the Umberto Malapel and the Italian group that said that the coexistence of STK11 and KRAS mutations confers a worse prognosis to this patient in spite of high expression of PD-L1. So as quoting Albert Einstein, learning is experience. Everything else It's just information. So it's nice to learn from our experience, our questions, our doubts, and our mistakes, of course. And here are my conclusions. Conclusion number one is this. A non-comprehensive diagnosis by FNA and fine needle aspiration and fine needle aspiration biopsy of lung and mediastinum is a missed opportunity for us, of course, but also, and most important, for the patient. And conclusion number two is the clinical impact that biomarkers and cytology have in the management of the patients. And so the importance of the correct handling of these samples to generate materials success to perform PCR, NGS, FISH, immuno, and analysis of tumor microenvironment, because at the end, this is what we call precision medicine. So I want to thank to my colleagues in my department. We are a very small department, but very active and very enthusiastic. Of course, this photo was taken before COVID pandemic in 2019. So some residents and some technicians are not longer with us, but we have new people, which is always good. And yes, before to say thank you to all of you, I would like to ask, ask you to make a guess who is the cytopathologist in this picture. I think we all agree. So thank you for your attention, and I'm ready for questions. Thank you.
Something. I sometimes feel a little bit frustrated when my molecular pathologist told me that they have not enough material for NGS. In some cases, we do not have cell block, for example, from some bronchial brushing aspirates and so on, or the cell block is so paucicellular. And sometimes also the patient cannot afford a new sampling because of his clinical condition. In this case, yeah, I think we missed something. Do you think that with the new technique, the new sampling device, we can get more material, or how do you manage these cases where we feel a little bit uncomfortable and yeah?
Yeah, well, it depends. It depends because you are right. We have some cases that even all the efforts, we cannot send the material for NGS because it's not possible. So we are doing as much as we can to do that, but sometimes it's not possible. So we said to the oncologist that there is no possibility to do NGS. And I think it's something that bronchoscopies and echoendoscopies has to be familiar with. Have to understand that we need material for doing many things. So it's a teamwork. So they have to try to do as best as they can. They do, of course, but even though there are cases, of course, that it's not possible. So sometimes it's perfect, but sometimes it's not possible. The option in some of these cases is liquid biopsy, but it's another issue, liquid biopsy.
Yeah, we can talk in another long session about liquid biopsy. Yeah. And can also be this one-shot mutation. For example, you spoke about the idilia, a solution in case we have few cells and we need some molecular test, but we have to choose which one.
You mean which gene?
The idilia test, for example. Yeah. If we have only few cells, we can choose one-shot test for one marker.
Yeah. In that case, we talked to the oncology, and he said, "Okay, I'm interested in EGFR. Okay, do EGFR. Idilia now has a chart of translocation that is working very well, so it's a good solution too. Yeah. We can do most of the necessary markers. So there are many options, of course.
Thank you. There is a question for the web. What is your recommendation for internal controls in immunohistochemistry in cytology?
Okay, what we do in all the antibodies, we use the same control than for paraffin, but in PD-L1. PD-L1 is a very tricky. So in PD-L1, as I told in my talk, we use smear, stained smear from placenta for smears, and we use the regular controls we use is placenta, amygdala, etc.
Okay, thank you. So another question, do you find a wet suction technique is a similar diagnostic yield in EBUS as in EUS? In our hands, it seemed to be more useful in AUS.
Yeah, absolutely. In our hands, it's the same. Yeah, in EUS, it's very, very useful. It's very nice. We can get really core biopsies. But it's possible to do in some instance in EBUS, especially if you have a good bronchoscopist and the deletion allows to do that. There are many, many variables. But we have tried many times in EBUS. Sometimes we get this sample, some other times not. It's more difficult in EBUS, but can be possible. We have to try to do it.
Okay, so if there are no more questions, thank you very much again to do this talk twice, this morning and now. And I invite you to follow the news on the International Academy of Cytology website for the third webinar that will be in October. So have a nice summer to everyone, and thank you again, Professor Lozano, for your talk.
Thanks to you. Thank you.
Bye-bye.
Bye-bye.